Next in the pathologies of the optic nerve is the ischemic optic neuropathy. As the name suggests, the optic neuropathy, the neuropathology of the optic nerve due to the ischemia, is known as ischemic optic neuropathy, in short form ION. It can be divided into interior ischemic optic neuropathy or posterior ischemic neuropathy. Interior can be divided into arthritic ischemic optic neuropathy and non-arthritic ischemic optic neuropathy. Why does it occur? Because of the degenerative, vaso-occlusive or any vasculitic diseases. Vasculitic means inflammation of the vessel walls of the arterioles, not the arteries but of the arterioles. There is a compromise in the blood supply from short posterior ciliary vessels. Short posterior ciliary vessels which go around the optic nerve and from the annulus of them ahead. And hence there is an ischemia of the interior part of the optic nerve. Because of the compromise of the posterior ciliary vessels, there is the ischemia of the interior part of the optic nerve. What are the types? The types of ION, that is ischemic optic neuropathy, can be arthritic, or non-arthritic. What are the various forms of arthritic ischemic optic neuropathy? For example, in the cases of giant cell arteritis, where there is inflammation of the arterioles or some major vessels like this supratemporal artery. Advanced age is a particular risk factor for the arthritic ischemic optic neuropathy and mostly involves nearly complete vision loss. Less than 6/60 is the vision in these cases. As in the cases of non-arthritic ischemic neuropathy, it results for coincidence of the various cardiovascular risk factors in the patients with crowded optic discs. Crowded optic disc, for example, is seen in the case of hypermetropia. It is more common than the arthritic ischemic optic neuropathy, occurs mostly in a younger age group than AION, and few near total loss vision cases are seen. Very few cases have a very serious vision loss, that is less than 6/60. Mostly the vision loss is more than 6/60. Visual acuity is more than 6/60. What are the various symptoms with which ION presents? There is a sudden loss of vision or a visual field, often on waking up. When we wake up from the night sleep, there is sudden loss of vision or the visual field. Vision in that eye is obscured by a dark shadow. It is not like a curtain of a retinal detachment, it is just some dark shadow suddenly has appeared, and it often involves upper or the lower half of the vision and usually towards the area towards the nose. Okay, there is a visual field scotoma. Okay. Pain or scar tenderness is present in the cases of giant cell arteritis because of the involvement of that supratemporal artery. What is a giant cell arteritis? It is an autoimmune vasculitis in the patients over the age of 60. It affects the arteries with an internal elastic lamina. Okay, it affects the arteries which have an internal elastic lamina. Do the central retinal artery branches in the retina have the internal elastic lamina? No. But this giant cell arteritis affects the arteries which have the internal elastic lamina, like the supratemporal artery, the ophthalmic artery, branch of the ophthalmic artery. What are branches of the ophthalmic artery which have the internal elastic lamina? Short posterior ciliary artery, long posterior ciliary arteries. Central retinal artery has, but the branches of central retinal artery don't have an internal elastic lamina. Continuous internal elastic lamina is not present in the branches of central retinal artery. That is the retinal artery. Giant cell arteritis presents with any combination of sudden loss of vision, scalp tenderness because of the involvement of the temporal artery, pain on chewing, shoulder pain, and general malaise. Okay, and general malaise. What are the signs in this disease? There is a sudden reduction in visual acuity. The field effect is present, especially the absence of the lower or the upper half of the visual field, which is also known as altitudinal scotoma. There is swollen and hemorrhagic disc. Normal retina and retinal vessels can be seen, but the disc is either swollen or hemorrhagic, or any optic disc edema can be seen. The disc is pale if it is a arthritic ION variety, especially in the acute cases because of the sudden ischemia because of the involvement of the arterioles. The CD ratio is small, especially in the non-arthritic ION because of the crowding phenomena, and hence because of the crowding phenomena, the patient is at more risk. And the temporal artery is tender because of the inflammation there in the giant cell arteritis. This is the edema seen in the cases of NAION. Okay. What are the various investigations in the cases of giant cell arteritis? There is elevated ESR and CRP, and for confirmation of the diagnosis, we have to do the temporal artery biopsy. It has to be repeated if the suspicion is even if the biopsy comes negative, we have to repeat it. And the most important point is that treatment has to be started on the initial day of the suspicion, and we don't have to wait for the temporal artery biopsy report to come and then start steroids. The other investigation that can be done is the color duplex ultrasound, in which there is a hypoechoic halo around the temporal artery lumen which can be seen, and the full blood count has to be done to exclude any anemia, and blood pressure and blood sugar levels have to be seen. What is the treatment? Intravenous and oral high-dose steroids have to be started at the first visit if giant cell arteritis is suspected. The dose of these drugs is tapered over ensuing weeks according to the symptoms and response of ESR and CRP levels. You have to, this is a major point. Steroids will not reverse the visual loss, but can. Why are we giving the steroids? To prevent the involvement of the other eye, because NAION appears in the other eye by 6 months. AION can present even after a month in the other eye. So we have to prevent the vision loss of the other eye, and hence we give the steroids. If we are thinking that there is a vision loss and steroids will help in recovering of the vision of this eye, no. We have to save the other eye. There is no treatment for non-arthritic ION other than the management of the underlying risk factors and conditions. What is the prognosis? Second eye may rapidly get involved if untreated, especially in the cases of giant cell arteritis. The steroid therapy may have to be continued on prolonged basis, maybe years, 2 years, and has to be monitored. There is a significant rate of involvement of the other eye in a non-arthritic form, 40 to 50%, even in the NAION. It is unusual for the vision to get progressively worse in non-arthritic form. Means there is a vision loss, it becomes stable there, and progression is seldomly seen. Vision lost does not recover in both these conditions. Okay. After ION, AION, papilloedema, whenever there is a chronic inflammation, the optic nerve can go into the pallor. It may not work and present as an optic atrophy. What is an optic atrophy? Pallor of the optic disc due to the damage of the retinal ganglion cells, the fibers of the retinal ganglion cells, and optic atrophy occurs 4 to 6 weeks after the cell damage, after this ganglion cell damage. Why the ganglion cell damage occurs? Due to the reduced blood circulation or any inflammation, due to the ischemia or inflammation. Okay. What are the various types of optic atrophy? The optic atrophy can be either primary, secondary, or consecutive. What is a primary optic atrophy? In which the pallor of the optic disc occurs without prior optic disc swelling. And why this occurs? This is due to the retrobulbar damage of the optic nerve up to the lateral geniculate body. Okay. And the color of the disc is chalky white. You can see here the color of the disc is chalky white and the margins are well defined. Next is the secondary optic atrophy. What is secondary optic atrophy? Optic disc swelling is seen prior to the pallor. First the swelling occurs, then the pallor comes, and margins may be less defined. You can see here margins are not well defined, and the color appears dirty white to grey, and it is not chalky white as seen in primary optic atrophy. Next, the third variety is the consecutive optic atrophy. What is that? It is a consequence of diffuse retinal disease. Any diffuse retinal disease affecting the retina, and the findings are as in secondary optic atrophy, that is, there is a swelling of the disc prior to the pallor, margins are less defined, and the color of the disc appears dirty white to grey. What are the various examples in which the consecutive optic atrophy is seen? It is glaucoma, any previous optic neuritis as in cases of multiple sclerosis, any previous ischemic optic neuropathy, any long-standing papilledema of more than 2 weeks, 3 weeks, optic nerve compression by any mass lesion, either in the middle cranial fossa or the orbit, or a disease like retinitis pigmentosa, which is a diffuse retinal disease. Summary of the optic nerve disorders can be elicited from this table, in which the papilledema, the signs and symptoms associated with papilledema are headache, pulsatile tinnitus, and transient visual obscurations, in which there is a transiently the patient does not see something and his vision appears after about 10 minutes. And the papilledema is always bilateral, and visual acuity is spared and doesn't fall. Only in papilledema the visual acuity is spared, and rest all optic nerve disorders the visual acuity is not spared. Okay, and in the visual field there is enlargement of blind spot or the constriction of the visual field. All the optic nerve disorders are mostly unilateral except papilledema and infiltrative optic neuropathy. Okay. In the compressive optic neuropathy, we have to see these optociliary shunts. Optociliary shunts are a major finding to label the optic nerve disorder as compressive optic neuropathy. In the optic neuritis, we have to look for the pain with the eye movement and other neurological disorders. Next we come across what optic asthma. When is the optic asthma involved in neuroophthalmology? Any pituitary tumors, and how do we diagnose pituitary tumors? Because symptoms related to the hormone disturbance will appear. Meningiomas or craniopharyngioma will cause the compression on the optic chiasma and involve the optic chiasma. How does it present? The involvement of the optic chiasma, if it is in the middle, the nasal fibers of both the retinas will be involved, and there will be the patient will present with bitemporal hemianopia. There are missing objects in the periphery of the visual field. There is difficulty in fusing the images. Because of the involvement of the temporal half, there will be difficulty in fusing the images, causing the patient to complain of diplopia, although the eye positions and movements are normal. Okay, there will be a fusion problem. Difficulty with tasks requiring stereopsis, such as pouring the water into the cup or threading a needle, becomes difficult. This all is because of the diplopia, which arises because of the loss of binocular single vision. All these symptoms are because of this in the bitemporal hemianopia caused by the optic chiasma involvement. Next is the involvement of any optic tract radiation and visual cortex. We have to remember that when the tract is involved, the cause is mainly vascular neoplastic. If the optic radiation is involved, cause is mainly neoplasia, and if the cortex is involved, the cause is mainly cerebrovascular accident. The presentation is homonymous hemianopia in the visual field. If the tract is involved, involvement is incongruous. If the radiation of the cortex is involved, the involvement is congruous. And visual loss is of rapid onset or slow onset, suggests any space occupying lesion. Okay. If the tract is involved, optic tract, it is an incongruous involvement. And if the radiation of the cortex is involved, it is a congruous involvement. We have already, congruous means almost equal involvement of visual fields in both the eyes. Incongruous means almost a quarter is involved in one eye and the full hemifield is involved in the other eye. That is the point I have disparity. So with this we finish the neuroophthalmology, and thank you.